Welcome back to Plab Talks. This is episode 3, and we're continuing our focus series on headache.
Let's shift again. Migraines. These can be quite varied in how they present, can't they?
They certainly can.
We've got 2 cases here. First, Joan Smith, 35-year-old lady in the emergency department. Sudden, dull, static headache. Left side, severity 8 out of 10.
Okay, severe unilateral.
Light makes it worse photophobia. She feels nauseous. And she has blurry vision with a horizontal line. She's had similar headaches before, including one just a week ago.
Right, pattern emerging, visual disturbance.
Then we have Dana Williams, 28. 3-month history of throbbing headache, sometimes right-sided, sometimes left, feeling sick. Then she sees flashing lights before the headache starts.
Flashing lights. Oh.
And she's worried about a brain tumor because her aunt had one. So what are the key features here pointing towards migraine? And what's this aura business?
Okay, the common thread, despite those slight variations in description, is the nature of the pain, often throbbing, often one-sided, though it can switch sides or be bilateral sometimes.
Right.
And importantly, it's coupled with associated symptoms like nausea, vomiting, and that marked sensitivity to light, photophobia, or sometimes sound, phonophobia.
Okay.
Now, Joan's blurry vision and the horizontal line and Dana's flashing lights, these are classic examples of a migraine with aura.
Aura, so that's the warning sign.
Exactly. Specific neurological warning signs, usually visual but can be sensory or motor, that precede the headache itself, typically developing over 5-20 minutes and lasting less than an hour.
Got it.
And the real nugget here for you is knowing how to differentiate and reassure. It's particularly important for patients like Dana, worried about brain tumors.
How do you reassure her effectively?
You'd explain gently that brain tumors typically cause progressive headaches. They get steadily worse over time, often worse when lying flat or first thing in the morning, and frequently associated with other neurological signs or seizures. That pattern just doesn't fit her story.
Okay, reassurance is key. Once you suspect migraine, what's the immediate treatment you'd consider, say, in the ED for Joan? And then how do you help someone like Dana manage this long term?
Right, for acute migraine, like Joan's presentation, a high dose of soluble aspirin, say 900 milligrams, can be very effective. Often given with an antiemetic like metoclopramide or prochlorperazine. The buccal prochlorperazine 3 milligram is quite handy.
Okay, aspirin and anti-sickness.
Yes. Connecting this to the broader picture of acute migraine management, first-line treatment also includes simple analgesia like ibuprofen, perhaps at a higher dose than usual.
And if that doesn't work?
If those prove ineffective, then you move to specific anti-migraine drugs called triptans. Sumatriptan is the commonest example. But you always need to carefully consider contraindications, things like uncontrolled hypertension, ischemic heart disease, previous stroke, or TIA. Very important check.
Right. Check the contraindications.
Yeah.
And long-term for Dana.
For long-term management, encouraging the patient to keep a migraine diary is absolutely crucial. Cannot stress that enough.
Why is the diary so useful?
It helps them, and you, note patterns, identify potential triggers, food, stress, sleep changes, hormonal cycles, and track how well treatments are working. It gives the patient fantastic insight into their own condition and empowers them.
And what about preventing these attacks? They can be really debilitating. For patients who are getting them frequently, what are the options for prophylaxis?
Yeah. Improving quality of life is the goal here, isn't it?
Absolutely.
For prophylaxis, if the headaches are frequent, the usual threshold is maybe more than once a week, or perhaps fewer, but very prolonged or disabling attacks despite good acute treatment, then we'd consider starting preventative medication.
Okay. What are the first-line options?
First-line options are often beta blockers, like atenolol or propranolol. They can be quite effective.
Yeah.
Alternatively, a low dose of amitriptyline, especially if there's coexisting depression or sleep problems, can be a good choice.
And second-line?
Second-line options include drugs like topiramate or sodium valproate, though you have to be very careful with valproate in women of childbearing potential due to teratogenicity.
Right. Important consideration.
Very. And in some specific refractory cases, botulinum toxin type A injections can be considered, usually via specialist services.
And when do you refer to neurology?
Referral to a neurologist is definitely warranted if first and second-line prophylaxis options fail to control the headaches effectively, or if the diagnosis is uncertain, or if there are atypical features.
Thanks for tuning in to Plab Talks. We'd love to hear your feedback, and we'll be continuing the headache series in the next episode. Stay curious, and see you soon.